As Innovate Connect, we're trying to bring people together across industries and across disciplines. In the spirit of doing that, allowing people to share these ideas that are used outside of our normal purview and bringing them together and saying, how can I reuse that concept or reuse it in this area? So that's what we're working to do. Today we have Zarir Irani as a co-host. He's an alternative host to support in case we have a technical failure along the way. We have three distinguished panelists that have joined us. So we have Donna Bembenek, and she is the president of Waukesha Catholic Private School, and she has also been the national vice president for marketing for the YMCA. We have Christopher Jankowski, Dr. Jankowski. You can see he's in his doctor garb. I think he probably stepped away from work to be with us for this hour. He is a doctor at the Mayo Clinic and faculty of the Mayo Clinic College of Sciences, and has been focused on leading quality improvement methodologies across the medical industry. In addition to that, we have Dr. Volker Schrage from Dortmund in Germany. He is a private general practitioner in a clinic in Legden, Germany, but he is also focused very much on company health management within their practice, and is the chairman of the Representative Assembly Association of Statutory Insurance Physicians, which he was describing a little earlier to me as a compulsory organization that physicians are part of inside of Germany, and they help manage policy and insurance payments for the physicians across regional areas in Germany, with Volker's focus in Westphalia, Lippe region. So welcome panelists, and thank you for joining us here today. Thank you for participants for joining as well. We will be going through each panelist sharing a bit of background around three main things. What impact have they been experiencing as it relates to COVID-19 corona? What tactics or innovation have they put in place in order to cope with that? And what do they see the future? This is going to be sort of a free-form conversation today, and we will go through each panelist sharing their thoughts about those three things. And at the end, we hope to reserve 15 to 20 minutes or so for questions, Q&A. At the end, you see have a Q&A button on your screen as a participant. You can begin to log questions anywhere throughout the process today, but we will not take questions until we get to the end of our introductory comments from each panelist. So without further ado, I'm going to hand the microphone off, so to speak, to Donna, and she is going to give us kind of her background and share those experiences, those impacts, and what she sees as the future from her perspective. So thank you and welcome, Donna.
Thank you very much. I'm very, very honored to be here with both Dr. Jankowski and Dr. Schrage. It's an important conversation as what we learn about the coronavirus and how it spreads and who's at greatest risk and how to prevent people from getting ill. These things we're learning as we go. What we know today is far more than what we knew on January 1st. And that information can help us make better decisions and help us protect individuals in our individual communities, but it also helps us really maybe calm some fears, particularly I deal with students and teenagers. And I was on a Zoom call with our teenagers yesterday as they participate in our return to school planning, and very interested in how informed they are, how much they're reading and learning about the coronavirus and its impact and effect, and how desperately they want to come back to a school building and environment. So the questions are, what has been the impact? what have been our tactics and how have we looked at innovation, and certainly how do we think this is going to affect our future? So from an impact perspective, I, like many other school leaders around the world, have had to address and move quickly on a pivot. And for our state of Wisconsin and the central part of the country in the United States, we were asked in the middle of March to close our schools as a directive of the Department of Public Instruction and the Governor and Department of Health, and for the safety and well-being of the whole state, as we tried to stem and flatten the curve, as they say, so that we could make sure that we could support and serve the most critically ill. So we had to quickly pivot. Our teachers were very swift at their adaptation of technology to help make those moves happen and create a consistent, continual quality learning environment for our students. Some of the impacts and some of our challenges, as everybody's intent is always very positive, one of our challenges has been conflicting information that oftentimes is understood from our various agencies that we look to for advice, whether that be the CDC, Wisconsin Health Organization, or I'm sorry, the World Health Organization, DPI, DHS, the Department of Health, even the American Academy of Pediatrics, all have different perspectives on what's the best strategies for approaching this within a school environment. I work regularly with my colleagues around southeastern Wisconsin, superintendents of schools, presidents of private schools. I'm also working on a bi-monthly basis with colleagues throughout the country who are running schools, so that we can share what are the best technologies that are helping run schools right now, what are the best practices, how do we think about the consideration of children. So much of the research has talked about how the asymptomatic children, how serious is this for kids, how much do kids spread this, and what's the risk to children. We also are an employer. So as an employer, how do I protect faculty, which in our case, many of our faculty have long tenure and have themselves might be in various categories of risk themselves and more susceptible. So faculty are very concerned about attracting this and what's the transmission potential from their students, but also from each other. So you can imagine how a science department or the math department comes together and typically would collaborate. That could be a risk, because if our math department shares this with each other, you could quickly take out a whole faculty of staff within a certain discipline because they work so close in proximity to one another. So those are some of the impacts. The questions and things that we don't really have answers to yet around what to do if a student lives with someone who tests positive, what to do if that student themselves tests positive, and as we head into back to school and all the criteria, what to do if a student just has a headache or might just have a flu or the cold. And is this coronavirus? Is this something not as concerning? Contact tracing, how do we effectively contact trace in high school? Some of the advisories have been try to keep kids together in small groups and pods. But when you have a freshman, a high-performing freshman, high-level, high-achieving learner, that might be a freshman in high school, but taking a junior level science class or math class, they intermingle far more than what might happen in an elementary school, and it's much harder to keep them in pods. So we're trying to figure that out, and what's practical in terms of opening a high school, best practices, things that we want to be able to do, and then what can practically be implemented around social distancing, testing. I'm interested to hear from the doctors about testing because certainly if you test too soon, even after exposure, you might get a false negative. And so we're not sure if testing day one, having everybody test before they come in, maybe won't really yield the kind of results that we're looking for, or the information, I should say, that we're looking for. And certainly symptom checking, what's the best practices around temperature checking? It seems to be the kind of the common practice to temperature check everybody. We know that thermal temperature thermometers might give a false rating because of 90-degree temperatures outside of our school one day as kids are driving in hot cars, driving to our school when it's 90 degrees outside, coming into the building and then having their temperature checked. So all of these are impacts on how we run a school to keep people safe. We certainly are worried about the safety of our children, but it's really how do we protect the faculty? The best way to keep schools open is to keep faculty healthy. And so we have to think about how we do that most efficiently. Probably the most contentious conversation comes around the need and importance of wearing masks. It's not kind of a common practice where it is around the world. In other parts of the world, it's not as common. In the United States, and particularly in a rural area that many of our families come from. So we're really trying to educate and inform people around the use of masks and the important role they play in preventing the spread. From a tactics innovation perspective, we certainly have made a quick pivot to innovation around technology and how we use technology to educate and to help accelerate learning and to complement learning. So immediately we went to many of the technology solutions that other schools have been using and have been doing flipped classrooms, have certainly been using Zoom and Teams, Microsoft Teams, certainly Seesaw, many of the type of applications that other schools are using. We are installing and have been spending the summer installing web-enabled classroom device, so we can have webcams in all of our classrooms. So it allows families to make a decision about what's important for their family in terms of health, but also if a student is not feeling well, we want them to stay home. And this way they can, even if it's, I have a headache or I have a sore throat, please stay home and participate in school virtually and remotely, synchronized learning where a teacher will be in the classroom with many of the class and then others at home being able to participate virtually. So many of the technologies that we're using to help augment our educational experience will continue. I think that from a future perspective, I think there are going to be many key benefits that come from what we are experiencing, if anything, around education and the use of technologies and the opportunities for technologies to aid in the education and how education can now be really provided from anywhere. We have international students. We have students all from over the world. Many of those students opted to stay in the United States for this summer other than going home for the fear of not being able to return because of travel advisories. But some are still went home to their families and may start school with us using technology. And that will allow them a continuous learning opportunity that might not have otherwise been available. And it does provide families and students, certainly, as technology continues to develop from the future of education, how we might be able to to share education and provide even kids in the most rural areas. We did identify our students who might have been technology lacking. We made sure everybody had devices that needed the devices. We also made sure everybody who did not have internet access, we provided that to our students. We identified who would be at risk when we went remote to begin. We didn't want to have any child fall through the cracks because of a lack of technology. So certainly technology provides some new opportunities in terms of those staff that are not non-faculty staff being able to work remotely to limit the number of people in our building, but then also allowing students to continue their learning even if they can't be physically in the building.
Well, thank you, Donna. I'm sure there's a lot of questions about schools and how they're going to be handled. So we'll get to those. But Chris, we want to move the conversation to you and hear a little bit about what's happening in your world, please.
Sure, thank you, Chris. And echo Donna's statement about being honored to be part of this panel. It's really a nice opportunity. I woke up this morning and I checked the Johns Hopkins coronavirus website, and as of this morning, we were at 3.5 million known cases in the United States, and about 130, actually more than 137,000 deaths. I saw a projection yesterday that will be up to 201,000 by November of this year. And there's been some news in the past week about the potential for a vaccine. That's probably very unlikely that we'll have anything by the fall or even by the beginning of the year. Everything's in very early stages. For healthcare, this has been an absolute paradigm shifting event. We all knew that something like this was possible. We've known about this for a long time. And actually, as many of you have probably heard from listening to the news, that much of the public health issues around this have been kind of solved. Mask wearing, social distancing, contact tracing, those are the pillars of the public health response to the virus. But this is a new virus. And so understanding the acute care of it is something that we're still challenged by. Institutionally, we like to think of ourselves as having three shields: clinical care, research, and education. And the virus has affected all three of those in profound ways. With regard to figuring out what we were going to do, we very quickly developed a research infrastructure to begin looking at both clinical outcomes and basic science related to the coronavirus. But this is a slow process, and it'll continue for several years. I've been watching the medical journals since March, and right now, basically to Donna's point about having a variety of information thrown at us, right now all you need to do is put coronavirus on a paper and it gets published. And I've seen papers in our major journals that haven't even been typeset. They've been published with just the Word documents or PDF documents that were sent in. So there's a lot of sifting of information to be done at this point. With regard to clinical care, in southern Minnesota, we've been very fortunate with regard to the burden of the virus we've had thus far, but our initial projections were that we were going to be hit fairly hard. We were especially concerned because we have a large number of international patients that come to the clinic, and we were worried that they may have brought the virus with them. And in addition, our staff travels quite a bit, so we were worried about exposures through travel. One of the first things we did is ramp up our capacity to care for patients, and we converted one of our large pre-op, post-op areas to an ICU, and that involved the mobilization of numerous resources, ventilators, et cetera, et cetera. Thankfully, that's not been needed, and right now we've got only 20 patients here that are COVID patients. I didn't get a chance to check this morning how many were in the ICU, but our capacity has far exceeded our need at this point. With regard to education, the virus has been very, very impactful because we had to cease all educational activities in mid-March due to the virus. we made the decision that it wasn't proper to have residents and fellows and medical students and other trainees in the clinical environment until we had a better handle on what was going on. And because of the social distancing requirements, most of our learning conferences have been canceled or converted to Zoom. So that we've had to be quite nimble in terms of determining how we might serve our learners in a way that's meaningful for them. And we're still working on whether or not we've hit the right cocktail, if you will. With regard to clinical care, in March, in response to our governor here in Minnesota, we ceased all elective procedures. And many of you may have heard through the media that a lot of hospitals have had significant financial impacts from the coronavirus because of the cease in procedures, and we were no different. And there was a strange irony that we were hitting the biggest public health crisis of our lifetimes, but at the same time we hit that because of the healthcare financing structure in this country. Our hospital and many others faced significant financial difficulties. So we ended up trying to balance how we provide clinical care to patients and how we maintain the institution. It was actually an issue: can we survive? So we've been juggling that since March. We had a complete pause on anything but absolute emergencies for 3 weeks. And we've slowly ramped up elective and urgent care since then. And that's caused a remarkable backlog now, because many of our patients are cancer patients, and we can't delay their cases very long. So right now we're trying to play catch up, and I know for some of our service lines, we're up to 2 and 3 months out, which is very unusual for us. We typically like to have surgery the next day once the decision is made to operate, and that's just not possible for us anymore. We've also, in terms of finances, have our entire staff took a pretty healthy pay cut, and we furloughed roughly half of our employees. Many of them are back now, but it's forced us to think very differently about how we work here. Much of our research now is being done work from home. Many of our physicians are actually working from home doing telehealth. And looking forward, that may be something that we may continue, because patients have found it very convenient, and some of our providers have actually been quite satisfied with doing that. There are obviously things that can't be done in a online fashion, but it's worked quite well. I alluded to our international patients, and financially that's been a struggle for us, because most of our international patients are full pay, and we don't have the issues with insurers and Medicaid and Medicare that we face with United States patients. And so they're a source of revenue for us, and they're not coming. So we've had to struggle with that a bit. But the other thing is that we're in July now, and many of our trainees are international, and they're very talented, and they haven't been able to begin their training. And that's been a source of concern for us, because we take our staff primarily from our trainees. So as we have retirements, et cetera, we don't have the bench that we normally have. So we're looking forward to thinking about how we're going to maintain our capacity and our quality as the long-term fallout from the coronavirus happens. We're also beginning to ask what's really necessary in terms of healthcare. Clearly cancer operations are important, but many of the things that we routinely do in healthcare, we're asking about the value of them and whether or not it's worth putting patients at risk by coming to the hospital to have these procedures done or evaluations done. So we're thinking more and more about that. And an interesting kind of side effect of the coronavirus is, for the first time in my career at my institution, we're thinking a lot about the safety of our staff. And it's always been kind of in the background that we want to be safe. But this has been a real issue, providing adequate PPE, defining what procedures are particularly at risk for transmitting the virus, et cetera, et cetera. And there's a renewed focus on that in our institution right now. And I think that's been actually very helpful going forward. And it's helped the staff weather the storm. The final issue with regard to staff is that many of our staff has had, they've got school-age kids, so they've had to juggle homeschooling with an exceedingly stressful environment at work, and it's been very difficult on them, and we're still working through how to support them best, and that's going to be a long-term process, I think, because I'm not sure going forward what our schools are going to look like here in Rochester as well. And I think I'll stop there and take questions later.
So thank you, Chris. Very insightful as well. And I see there are some questions starting to come in. And of course, for those of you that are participants, feel free to add questions. We will get to all of them that we can after we've had each of our panelists share their thoughts. So Dr. Schrage, will you share with us what's happening in Deutschland and how you're coping in the Westphalia area?
Of course I will. I'm pleasure to do this. Can you hear me? Is my mic on? Yes. And first of all, I'm also very honored to take part in this great event. And I heard a lot of things from my both panel colleagues that I have to think about. But first of all, I want to tell you a little what happened here. And I have to explain a little because we're in a totally different system, but we can still learn from you. In Germany, we got the organizations like the one I'm a chairman of. That's the Association of Statutory Health Insurance Physicians. And it's a compulsory membership for all the people who want to work with the health insurance. I was also affected by the COVID as an employer of 2,000 people working here, and as a general practitioner, which I've been since 32 years, in a clinic on the countryside with 4 doctors and 15 employees. I'll tell you about the KVWL at first. We're a government corporation that represents about 15,000 physicians and psychotherapists. And we take care to see that there are enough GPs and specialists and psychotherapists for the requirements of all the regions. Westphalia-Lippe has a population of about 8 million people, and we have to care for them. That's our job. We negotiate the financial compensation with the health insurance and distribute the money to the doctors. At the beginning of the pandemic, it was essential for us to keep up medical care for the populace at all means. It was important to avoid a wide range shutdown of the ambulant clinics so the people will not have to go into the hospital, and so we would avoid dramatic conditions that we saw in Italy shortly before the pandemic reached us here. Therefore, our maximum of action was test and separate to interrupt the chain of infection. Patients who were suspected to have COVID-19 were kept out of the clinics, even out of the ambulant clinics. They had to call and get their appointment, and then they were led in one by one through separate entrances and treated in separate rooms, only by staff members and doctors with protective equipment. But in the beginning of the pandemic, we lacked protective equipment badly. We didn't have enough at all to do the job. So we as an organization built up about 670 diagnosis and treatment centers all around Westphalia, mostly in old school buildings and containers and in other places where we could get a hold of. We had computer technology in all of these places for patient identification and recording, and the elementary medical equipment, but all that was necessary to treat COVID and all the patients with COVID. The goal was to keep the people with COVID out of the normal practice or clinic. Our employees, I forgot to say, in this way, we had luck, we had a lot of luck, and thank God we kept 6 out of 7 COVID patients out of the hospital. And the hospitals were mostly void at that time. They're just running up to old form now. Our employees out of our organization built up those treatment centers in a matter of hours. The work in these centers was accomplished by volunteers, doctors, and staff members. They were, of course, reimbursed for their work. We also had to see to it that the capacity of the laboratories, which didn't work at this level, had to go up fastly, and they did a very good job on that. Since we didn't have enough protective equipment in the beginning, we went out on the world market and shopped there. And that was sort of exciting to see what happened there. Talk about that another time. We didn't have enough disinfection material. As one of the nice stories that happened around there, we worked with a local distillery who turned good old German schnapps into a disinfection fluid that we could really use. Testing and separating was the biggest success factor in Germany. After the pandemic slowed down, we built back the treatment centers, but we got to be aware there was another breakout in one area. In a slaughterhouse, about 1,500 patients were infected. We had to build up 5 centers again, but that is done by now. We'll stay alert and are prepared to build up the infrastructure again, sort of like in some kind of flexible response. All costs of the required treatment and all costs we had were paid for by the government out of healthcare system and special funds, so we don't have the problem that you, Chris, had. That is one of the assets we have here, whereas we can talk a lot about the system. We got a lot of complaints about it, but now there it worked. In our own organization with 2,000 people working here, 900 on this place, the biggest challenge was to keep Corona out of the building, because if we shut down, then the whole organization will probably not work, because we distribute the money, we distribute a lot of other things and care for that it works. And if we are not there, then it won't work again. We reduced the people working here, had a lot of home office working, and a lot of people went home. That's possible through German law giving, which compensates that to an organization in certain times of catastrophe. We had a plan to shut down totally, but of course, happily to say we didn't need it. We increased telephone and video conferences in this house. Business trips were not allowed anymore. We had a lot of trips going to the different doctor's offices and to the health insurance, but not allowed anymore. And there were no meetings in-house anymore from people coming out of the house. And it was an obligation to wear face masks in the building the whole time, except when you're sitting in your office. Working hours were expanded from 6 in the morning to 8 in the evening on 6 days a week. And the canteen was shut down for 3 weeks, and then we put it up again with very strictly hygienic rules. As a GP in my clinic, we reduced the consultation hours to an absolute necessary. We kept contact with our patients, especially the elderly, per phone or by telemedicine or video consultations, which I'm happy to say worked very well in nursing homes, and especially with the elder people that did a good job on that. Handout of medication prescription was done through a window, which a lot of the clinics did after the people had called and ordered their medication. We intensified the hygienic regulations in the clinic, and pregnant employees were sent home, and even such employees with a high risk were sent home, which is even possible in Germany because of social legislation, which pays for short work and compensation in catastrophe times. As a future, I have to say, as one of the chairman of the KVWL, I have to say there's no life after Corona, it's life with Corona. We'll have to, all of us will have to count on it that there might not be a big pandemic anymore, but clusters will come up anyway. So we have to live up to the virus and to the challenge. We're defining the processes of coping with this, with a new eruption now, and we're communicating with other players in the health system, with like hospitals, public health service, and nursing, to be prepared for new outbreak. We have a plan of action for new eruptions and define clearly who's responsible for what action to do. And as an employer, I have to say we want to really, in doing this, take the thrust of pandemic has given us to speed up the digitalization with video conferences and health conferences, same as we do in the practice. And especially what we do as in the practice and from our organization, we increase prevention measures, especially we're putting up a vaccination event in the fall against influenza and pneumococcus, because if the people get that additionally to Corona, you can count the days. And wearing a face mask in a clinic and in hotspots will be obligatory. And the normal hygienic measures, which we almost forgot, like washing your hands and keeping a little distance, I think we'll do a good job on that. So I'm very thankful. We got the new count today. In Germany, as of today, we have a little over 200,000 infected people with a death toll of 9,078 by about 80 million inhabitants. We were lucky. I hope we'll stay lucky. And I am happy to be on this panel to learn from you how you cope with the problem, so we can learn to take some of the things over here. Thank you very much.
Thank you, Dr. Schrage. We have some questions coming in, and with our limited time, I'm just going to get right to them. So I'll take them in order that they came and try to eliminate or sanitize any overlap. But let's try to spend just a couple of minutes on each question if that's possible. But the questions are important. So this question is, I think, for anybody in the group. And it says, focusing on health safety of customers or financial health of business, not including health safety of employees, could be problematic. And I know you talked about this a little. I don't know if you want to talk about it just a little bit more. How do you balance the health safety of all three? And all three are the health and safety of customers, financial health of business, and then health of your employees. Any additional thoughts on those from any panelists? Excuse me, from any panelists.
The Institute for Healthcare Improvement has a schema that they use to define the quality of a healthcare institution. And they've got three arms related to patient experience, population health, and cost/value. In 2015, they added a fourth criteria, and that was the health and safety of employees. And it makes perfect sense because without employees, you can't provide health care. And there are many healthcare institutions in this country that have adopted that, which is remarkable because things in healthcare move pretty slowly, and to go to actually adopt that sort of thought process over 5 years is pretty remarkable. And it's been done starting back in the early part of this century that healthcare organizations in pockets throughout the country have been doing that. But the question is really key. It's how do you balance that? And for us, I'll give one example is that we were concerned about PPE initially, and we were maybe a little too cautious the health of our staff initially, and we were not able to serve as many patients as we needed to. So we've been a little bit more thoughtful about what procedures require extensive PPE versus not, so that we're able to serve more of our patients. But our staff recognizes that there's some ill-defined small increased risk that they're being exposed to, and it causes a lot of stress. And again, this is something that as an institution and as in a healthcare system broadly, we've not faced before. So we're all trying to figure it out as we go along. And I'm not sure that we're there yet, to be honest. I'd be interested to hear what Donna and Volker have to say.
Yeah, I can add to that too. So certainly one of the things, so our customer being our students and our parents, we are a private school, so they pay tuition to attend our school. We certainly have employees that we have to be concerned about, and the financial well-being of our school. Right now, in terms of how do you balance that, certainly health and welfare of all in our community has to be the priority. This includes our employees. And as we communicate with our families, as we communicate with our students who may not feel personally the need to wear a mask for their own protection, what we have really talked about is their role as it follows with our core values of our organization to protect the teachers that they care about deeply and protect those others in their community, even if it means wearing a mask where they might not personally feel the need to do so, but saying that this is how we're going to keep our school open is by keeping people healthy, and masks are shown to be able to do that. So we are appealing to people to think beyond, to think globally and what's for the good of all and what the science is telling us. From a financial perspective, certainly we are looking at, we've spent a lot of money on plexiglass and PPE, and we're adding extra sanitization. We're adding extra people to make sure that the facility, anything common areas, door handles and chair rails and steps up and down the steps. So we have to keep this building safe and healthy. So certainly there are some financial impacts. We've been applying for grants that have helped offset some of those costs, and we'll continue to do so. But yes, we were going to have to look at the how we're going to make sure we're financially able to continue to invest in the things that keep our school healthy. But it is definitely a balancing act, but employee safety, we are an employer, and so employee safety is paramount.
Well, I can support that totally what you two said, because without our employees, without our doctors, the whole thing will break down and we can't care for the people. Right. And we also have a certain financial aspect. If we don't treat enough, then we don't get enough money out of the funds. But another aspect we got to think about is when we shut down too much, patients don't come to treatments who have other maladies and other diseases. And I know of some things where people suffered because they didn't come into the practices because they had, or in the clinics because of Corona. And so that's an aspect. The problem is that we didn't know how aggressive the virus was, and we got to get to know it and live with it. That's the problem.
All right, super, thank you. We've got quite a few questions coming in. Very quickly, if we can, the next question was, are we seeing differences, and that this question was for the docs, related to children versus adults, and what do we know about that so far as related to infection rates? And I think this will have a lot of implications on the schools as well. Any thoughts or data on that you could share, or if you will?
Well, if I may say something to that. As far as I know, we don't have any valid data on that yet, but it seems very much to be same as with the flu, that the kids are very fastly infected, but don't have much of a symptomology. They don't really appear to be sick. And so they transmit the disease very, very fast. It was a problem with our pediatric doctors who had to be very, very careful in the beginning. They were the ones we gave their protective gear the first. And so there is a difference in the affection. Elderly people are affected more, but kids, especially small children, they don't, of course they get sick, but not that sick, and it doesn't appear that much.
There was a review article in the Journal of the American Medical Association last week, and actually it was very well written and very approachable for the lay public, reviewing everything about Corona. And the data that they presented actually backed up what you said, Volker, and that's that kids, when they get it, don't have the same degree of illness that elderly folks do. And what they quoted was that 85%, or excuse me, 28% of patients over 85 will die of the disease once they contract it. But it's only a fraction of a percent for kids. What's interesting about kids is it seems that when they do get it severely, their presentation's a bit different than what we see in adults, and they have more vascular symptoms than we see in adults. So there may be implications in terms of severe cases in kids that would be different from adults. But in general, I agree with Volker that the severity of the illness, by and large, isn't as bad.
Great, thank you. And perhaps, Chris, if you could share a link after the meeting to that article.
Absolutely.
It could be something we could push out in our follow-up email to participants today, so they would have be able to look at some of that data themselves. We have another question. There's definitely a delicate balance between complete economic shutdown to minimize transmission and full reopening of the economy. The implications of the complete shutdown affect more people in different ways. And I think there is a question lurking in here around the mental health of people and trying to create the balance between economic shutdown and full reopening. Thoughts on those, tactics, ways to deploy, impacts?
Well, we have to be very careful about the people who are closed up in their home, especially older people, especially people in nursing homes. We had a lot of problems with that, getting depressions and going down mentally. And so our psychotherapist went on with video consultations. But we got to, like Chris said before, we got to see how important is it? How hard do we have to shut down? I think we really got to talk about flexible responses, because especially those people need care and need human care, need people to handle them and see them. And it was really fantastic to see when the nursing homes were opened again and the relatives could come in and see their grandmother or grandfather again. It was really touching. And so we shouldn't, well, it's a very difficult balance, but it does affect the people.
Yeah, like the doctors have said, you know, and somebody had mentioned earlier, I think Dr. Schrage, how pediatricians were the ones to first receive the PPE because they're in close proximity to children. I would say that there's a lot of similarities to our schools. So when we talk about this balancing of keeping things shut down versus getting the economy moving and making sure that we're protecting the people that are supporting our children, certainly we know the mental health issues for children are very real in this world where we have closed things down, not just school, but things that bring them joy, where they can come together and be social. When we talked to our students yesterday, they were very disappointed about the extracurricular activities that how they come together. They learn through those, but they also are socially engaged through those. We certainly don't want kids spending all of their time on gaming systems. We want them outdoors. Kids need to be in nature. So yes, there's this big balancing act. I think the answer to this balance is that people have to be willing to take some steps that will keep those who are serving our communities and keeping these businesses open healthy. And the science that we know today, and science evolves as doctors learn more and scientists continue to learn, the advice evolves. And we have to understand that because there's differing advice or changing advice only is because the doctors are learning more. And so advice evolves. And as long as we're willing to take the steps to keep those working to move our economy forward, teachers, doctors, business owners, it might mean that we have to do things we're uncomfortable doing or not used to doing, but it helps keep the economy moving and gets kids back in school and gets families back outside of their homes. That's a good thing. But we just have to be willing to take steps that science tells us will make all of those things safer.
Yeah, I completely agree with Donna on that. As you were speaking, Donna, I was thinking about the parallel between the scientific method and PDSA cycles, and you know, we're doing basically one PDSA cycle after another right now, and I think it would be helpful as leaders if we're very direct with those we're speaking with and saying, this is what we know now. This is our best practice today. It may change tomorrow, but this is what we believe needs to be done now. And I think there would probably be better buy-in if we could somehow approach things in that manner.
I think the other thing that we're doing, Chris, if I could just add, one thing that we're doing that I think is helpful to our families is we're making decisions 1/4 of the school year at a time. I think if we say to them, this is what we know now, this is what we know today, we'll continue to watch and evaluate what is the science telling us. And if we can make an adjustment safely for the second quarter of the year, we'll do that. But if we can take it off into pieces where it doesn't feel like that feels that this is going to be something permanent or long-term, but that we will continue to monitor the science and monitor what we're hearing. I think families at least feel like there's kind of it's an evolution, not something permanent.
Mm-hmm. There's a lot of innovation around short information cycles and learning in shorter, smaller pieces is kind of what I'm hearing. There's an implication in this question that I don't know that we can answer here today, but it is around what are the impacts to having the economic closure. So the medical system is running, even though it has a lot of issues. The school may have plans to move forward in some way. There are a lot of businesses that are shut down entirely. Are we seeing any spikes in mental health issues in the general population, or do we expect to see that anywhere in the future?
My colleagues that I've spoken to who work in that space tell me yes, that there has been an increase. But I don't have any hard data to share with anybody.
It's the same here. I think that the people have a lot more problems. We got to work that out. And the people fear new eruptions of the virus. And so it's a different quality of going around there.
All right, let's move to another question. We have one that says, have you found that your organizations, this is for all of you, your organization's longer term strategies or strategic initiatives have taken new shape as a result of your tactical experience working through COVID-19? So have you reshaped your approach to your organization's longer term strategies and initiatives because of what you've been through so far?
I'm happy to start. We actually had just approved a new strategic plan and had been starting implementation. So interesting that that plan has some emphasis on technology and how technology is going to benefit the school, our students, the learning environments. So certainly those opportunities around advancing technology's role in our school have sped up. Also, the need for additional resources for the various types of learners, and to make sure that we're supporting accelerated learning that requires some accommodations, the ability to apply learning in different ways. So I would say that certain pieces of our strategic plan have maybe moved forward in the priority list in terms of a 5-year plan and what we were going to do year 1, 2, 3, 4 toward a 5-year plan. So it might shift the rollout or the priority of some of the items within that plan. But it has not changed the plan, we have not said that we have to have a different plan. It just, we might reprioritize components within the plan.
Well, that's good to have.
One of our strategic initiatives was the word we use in our strategic plan is connect, and we're trying to reach more patients and the public in general in a more robust fashion. And this has actually accelerated that because we've had to be creative about how we see patients. And we're finding that for example, telehealth may be a very viable option going forward. And whereas it may have taken us 5 or 10 years to get where we are now, we're probably not going to abandon it once the crisis subsides.
Well, talking about innovation, we never had a challenge like this before. And from our history, like we are an organization here in Germany, a government corporation, we move very slowly, but now we had to move quick, and we had to change a lot. We have a good base. I think we got a good team up here up front. We got excellent employees working for us, highly dedicated, and who quickly added to our thoughts and helped us to move on. So I would say we have a good base, but like Donna said, we have to prioritize some things. And like I said in what I was talking about here, we're putting up plans to cope with new eruptions and cope with the scenery in the future.
Well, great, great. Thank you all. We're closing in on the end of the hour here. I really want to thank our panelists for taking the time out of their busy schedules to share with us what's happening in their environments. I think we heard several things that were tactics to deal with Corona, and then innovation as well, because we're in an environment that we had not foreseen, or as Chris said, we knew was coming, but weren't necessarily prepared for, and didn't know when it was going to come. I think it's changed a lot of things significantly long-term. We want to continue with Innovate Connect to put on these type of forums. There are a lot of different topics that we could talk about in this type of forum. We want to keep them rich and value-oriented to the participants and to the panelists themselves. One of the things that we want to do is we will send out a follow-up email to panelists and participants after the meeting today. And hopefully we'll be able to share the link that Chris talked about. And if the panelists have any other information that they would like to include, please do so. In addition to that, we are going to ask you for what your thoughts are about future topics you'd like to talk about. We believe at Innovate Connect that we want to do this on a monthly basis. We can do it on a shorter cycle if it's important. And right now, with the changes happening, it looks like innovation is something that we are all going to have to think about on an ongoing basis. So with that said, unless there's any final thoughts from you, Zarir?
No, I think that's precisely what we want. We want some ideas about, what topics are relevant to others, and we can certainly get the right people on these panels to talk through some of these ideas.
So, super, thank you. And thank all the participants for being here. We are at the top of the hour. Panelists, thank you so much for all of your contributions here today. We couldn't do this without you volunteering your time. Have a good day for the rest of your day. If you have more day in the United States, and have a good afternoon and guten Abend in Germany. And we'll hopefully see you all soon. You'll be healthy and well when we talk again. Have a good day.
Thank you, everybody.
Thank you, everyone.
Thank you for organizing this, and thank you for the good panel.
Yeah, very nice to meet all of you. Take care.
Yes,
Bye now.
it was.